Tushar, you can start now.
Assalamu alaikum, respected physicians. Welcome you all in today's Ecg study group presentation. Today is our 64th lecture session. As earlier sessions, we divided the program in two sections. The first part is the introduction to basic components, and the lecture will be delivered by Dr. Abdullah Al-Jamil sir. And the second portion, the clinical component, will be delivered by our respected Qrs Axis sir. Before starting of the procedure or proceedings, I'd like to request Professor M. Athar sir to introduce Abdullah Al-Jamil sir in front of us, and then we start the proceedings. Athar sir.
Thank you, Dr. Tushar, and good evening, everybody. Dear participants and honorable faculties and panelists, I like to welcome Dr. Rafiq Ahmed sir, Dr. Ashok Dotto, M. Shofiq, then Aisha Kader, Abida Tasnim, many others. So, sir, today our first presenter is Dr. Abdullah Al-Jamil. Actually, he needs no introduction, but still, I'm happy to say something about Dr. Abdullah Al-Jamil. Dr. Abdullah Al-Jamil is a man with multiple dimensions, sir. He's a unique person. Actually, he is a cardiologist, interventional cardiologist, electrophysiologist, poet, singer, composer, and possibly many other things I don't know. He's a man with a, and finally, sir, he's a unique human being. Actually, he has got many of the qualities. He is superior to me, I can say. He is superior to me. He has got many human qualities that I can follow him. So Dr. Abdullah Al-Jamil is not only such a person, he is also a good presenter. So our first presenter is Dr. Abdullah Al-Jamil. The most important and very difficult presentation today, that is the basic components. Actually, many of our participants actually interested to hear about the basic components. Last day, actually, they told that the basic components is not, this is not the basic. So Dr. Abdullah Al-Jamil, I will request you to present the basic components, and he will follow Dr. Professor Chaudhuri Hafizul Hasan, another man with multiple dimension, and actually another person. So he will follow Dr. Abdullah Al-Jamil. He will show some case presentation. So Rafiq Ahmed sir, I like to request Dr. Abdullah Al-Jamil as a first presenter. Dr. Abdullah Al-Jamil.
Thank you.
Thank you, Professor Adhar Ali. And you said overwhelmingly about me, but I'm not that much what you presented me before the audience. Today I shall talk on very basic thing, and these things usually people does not read from the books, but understanding these things would lead one person to interpret ECG very easily. So let me share my screen. Can you see?
No, Jamil.
Sir, it's not visible.
Might it take some time? Now?
It started. Yes, sir, it's visible now.
Is it visible?
Yes, sir, yes. Sir.
Okay.
So slideshow te done, sir.
So I shall be talking on the ABCD of electrocardiography. And first, the definition of ECG or electrocardiography is the graphical representation of electrical activity of the heart, which is recorded from the surface of the body. ECG is recorded by a machine which is a modified galvanometer. It records only the electrical potential changes of the heart, not the direct electrical activity. ECG provides very useful clinical information about myocardial disease, electrolyte imbalance, drug-induced heart disease and drug effect on the heart, conduction disorders. It is the most commonly used laboratory test for the diagnosis of heart disease. Let's see the lead systems. Conventionally, 12 leads are recorded, 6 limb leads and 6 pectoral or chest leads. Limb leads are 3 standard leads, 1, 2, 3, and 3 unipolar leads, and these are augmented, AVR, AVL, AVF. So here the V denotes the unipolar lead and A for augmentation, R for right, L for left, F for fourth. The pectoral leads, these are also unipolar leads, that's why it is denoted by V, and these are the V1 to V6 conventional pectoral leads. Standard 3 leads are bipolar leads and are called standard limb leads. Leads AVR, AVL, AVF, these are unipolar and augmented, and also the pectoral leads are unipolar leads. Electrodes of the limb leads are placed above the wrist and above the feet. Pectoral leads are placed as follows, as everyone knows. V1 in the fourth intercostal space, right of the sternum. V2, fourth intercostal space, left of the sternum. Then the V4 should be placed on the mid-clavicular line at fifth intercostal space, and leads is placed between V2 and V4 in a line on the middle point of the line between V2 and V4. V5 is placed on the anterior axillary line from a horizontal line drawn from the V4, and that cuts the anterior axillary line. That is the point where lead V5 should be placed, and the same line cutting the mid axillary line is the point for placing V6. And we also record the right ventricular right-sided leads denoted by V3, and here for right pectoral leads, V2 become the V1 and V1 become the V2. Then V3, V4, V5, V6 all are placed in similar way just on the right side as in the left, placed in the left side. These are the position, normal position, the 4 limb electrodes. The right electrode is for neutralization of the all 3 other limb leads. And these are the pectoral leads and V6 on the mid axillary line as denoted in this picture. Other special leads includes left-sided special leads, this V7 at the same line cutting the posterior axillary line in the fifth intercostal space, V8 mid-scapular line, and V9 left paraspinal border. And similar leads on the right side. And another one is esophageal lead. It is placed through the esophagus to the posterior to the left atrium. These are the leads that in the Ecg form, the waveform is in different leads shown according to the picture where the lead is placed, and this is the different forms of Ecg waveform. Ecg paper, small box 1 millimeter, large box 5 millimeter, and usual paper speed, it is horizontal boxes, standard 25 millimeter per second. Voltage calibration, the vertical boxes, standard 10 millimeter, that is 2 big boxes. Half standard 5 millimeter millivolt, this 1 big box. May have 10 or 5 millivolt. Standard for chest leads, substandard for the pectoral leads. As some lean thin person and young people have larger complex in the pectoral leads, so it needs to be reduced the um, uh, vertical calibration. So before interpreting an ECG, everyone must look at first the calibration of the voltage. This is the ECG paper. This is the large box and the small 1 millimeter box. Conductive system, as told in the 2 weeks earlier by Professor Atharali, the synovial node, internodal pathways. These are functional. There is no such histological pathway can be demonstrated. Atrioventricular node, bundle of His, bundle branches, right and left. Left bundle divides into anterior and posterior fascicle Parkinson's fibers. This is a picture that shows the SA node. These are thought to be internodal pathways. They converge to the AV node situated at lower portion of the interatrial septum near the tricuspid valve. And this is a bundle of His, and it divides into left and right. Here is anterior fascicle and there's a posterior fascicle. It's not shown in this picture. Mode of axial and ventricular activation. Axial muscle is activated longitudinally. That is, electrical impulse progresses along the fibers. Ventricular muscle is activated transversely. That is, the electrical impulse propagates from endocardium to epicardium. The atria and ventricles are electrically connected through the fibrous ring only by AV node and bundle of His normally. This picture shows this propagation longitudinally along the fibers of the axial muscle, and in the thick ventricle it propagates from endocardium to epicardium. Basic waveforms of the ECG. First is P wave. It represents the depolarization of atrial muscle. Qrs complex represents the depolarization of ventricular muscle. T wave represents the repolarization of ventricular muscle. U wave thought to represent the repolarization of intraventricular or Purkinje conductive system. Here is the diagrammatic representation of different waveforms. This P wave, the QRS complex, T wave, U wave, and here is the PR segment, the ST segment, and we shall come to the segment and intervals later. Now the intervals of the ECG. PR interval, it is the interval between two consecutive RR interval, sorry. It is the interval between two consecutive R waves. PP interval, it is the interval between two consecutive P waves. PR or PQ interval is the interval between the onset of P wave and the onset of QRS complex. Is the time taken for propagation of electrical impulse from SA node to ventricular muscle. QT interval, it is the interval between onset of Q wave to the end of T wave. It represents the duration of electrical systole. Segments of ECG. There are two segments. It's PR segment. It is that portion of the ECG tracing from the end of T wave to the onset of QRS complex. It is normally isoelectric. ST segment, it is that portion of the T wave. So this picture denotes the different segments and interval. Here first this PR segment, it begins from end of the P wave and beginning of the QRS complex. ST segment from the end of QRS complex to the beginning of T wave. Pr interval from the beginning of P wave to the beginning of Qrs complex, and Qrs duration from onset of Q wave to the end of Qrs complex. And ST interval is from the end of Qrs complex to the end of T wave. How the waveforms are inscribed. Electrical activity flows from negative to positive. If the resultant force of the electrical activity is parallel to the axis of the particular lead and flows towards the positive pole of that lead, it will inscribe positive deflection. If the resultant force of the electrical activity is parallel to the axis of the particular lead and flows away from the positive pole of that lead, it will inscribe negative deflection. If the resultant force of electrical activity is perpendicular to the axis of the particular lead, it will inscribe neither no deflection or a small equiphasic deflection. So this denotes the axis of the lead, the negative pole, this positive pole. When the electric resultant factor is exactly parallel to the axis of the lead, then it will inscribe positive large deflection. If it is little bit angulated, the deflection will be smaller. More it goes away from the axis of the lead, it becomes more smaller. Similarly, if it goes away from the positive pole, it will give negative deflection. When it is perpendicular, it gives equiphasic or no deflection. So here, according to these three colored arrows, from here we can understand this activation of the septal, which is first in the ventricle. It inscribes initial R wave. Then most of the electrical force is away from this AVR, so it inscribes inferior negative deflection. Again, it goes towards little bit towards the electrode, so again it becomes positive. Similarly, in lead 3 AVF in different lead, according to the position of the lead, the waveforms are changing. And also in the pectoral leads, from V1 to V6, gradually it changes its morphology. Somewhere it is equiphasic and then again becomes upright. There are three waveforms of ECG waves. There is one waveform is monophasic, only R wave or QS pattern. Two waveforms, the diphasic, either RS pattern or QR pattern. Three waveforms, the triphasic, this R, S, and R dash pattern, commonly says M pattern, and another is Q, R, S pattern, this W pattern. Now the electrical axis, the most difficult thing in interpreting in ECG, especially for the beginners and fellows. Also called vectors. Two types of axis, frontal plane axis and horizontal plane axis. Frontal plane axis is determined from the standard limb leads, so and augmented limb leads. First, we come to the standard triaxial reference system. The upper one is this lead 1, negative pole in the right arm, positive pole in the left arm. Lead 2, negative pole in the right arm, positive pole in the foot. Lead 3, negative pole in the left arm and positive pole in the foot. If we shift these lines toward the center, it looks like this. So one lead is away from another lead by 60 degrees. So it divides, there are 6 degree we can get from the center. So this will help us for calculating axis. Then the unipolar lead triaxial referral system. Here the unipolar leads, that is augmented AVR, AVL, AVF leads. These are perpendicular to the standard leads. So here is the AVR, it is perpendicular to the lead 3. The AVF perpendicular to the lead 1 and AVL perpendicular to the lead 2. So here also these are the equidistant with 60 degrees. So if we combine these two and plot on each other, so it looks like this, putting the heart in the center. And so there is every angle here again is divided from 60 to 30 degrees. So each lead is separated by 30 degrees. So AVL lead 1, 30 degrees AVR positive pole. Then lead 2 at 60 degrees, AVF at 90 degrees, lead 3 at 120 degrees, lead AVL at 150, actually it's positive, and it's 180 degrees. Similarly, the negative, the other portion denotes here. So this is called the hexaxial referral system, and if we can remember this, and it is easy to calculate the axis. But I would suggest for the undergraduate and fellows to draw this hexaxial referral system and put in front of your text, study desk. Look at it in the morning after rising from bed, and also before going to the bed. So this way you can memorize this picture. So examine 6 frontal limb leads. That is standard 3 leads and augmented 3 leads. Determine the most equiphasic Qrs deflection where it is present among these 6 leads. Inspect the perpendicular lead to it where the Qrs complex will be dominant upright and the Qrs axis is directly towards the positive pole of that lead. Normal frontal plane Qrs axis is -30 to 110 degree, though some authority considered is from 0 to 90 degree. Horizontal plane axis determined from 6 chest leads, and it is rarely used in clinical practice. So this the picture is the horizontal plane, and it is determined from the Qrs from the 6 pectoral leads. This is one ECG of normal ECG. So if we look at the normal Q waves, normal Qrs complex, normal T waves, and if we want to calculate the Qrs axis, the most equiphasic is at lead standard 1. The perpendicular to this is lead AVF. And on the either side of the AVF is lead 2 and lead 3. So here the lead 2 is larger than the lead 3, so it is more towards the lead 2, which is situated at the 60, and this is at 90. It is in between 60 and 90. So it may around 70-75 degree is the axis of this ECG. And another way of interpreting axis is rule of thumb. It's very easy. Put your thumb on the standard on lead 2 and AVL, and which way it is seen. and that from that which is upper, that is the axis. That was a rule of thumb is calculated, but it's not accurate. Axial referral system is the accurate. So thank you very much for patience hearing. I just presented the basic thing of electrocardiography, and for the normal waveform and normal QRS complex and association with pathology would be a separate lecture in future. Thank you very much.
Jamil, thank you for wonderful talk. I just want to take a couple of minutes and about this. I mean, this is a superb lecture for the audience. It's a very
Jamil,
simple lecture.
Stop.
It's a very simple lecture, but that's we need to learn. Simple and basic things are fundamentals of medicine or any knowledge, and to brush it up every day, as Jamal said. I want to talk. Yes.
I wanted to add, this is excellent, but I want to add one thing. For each of these, if there is a case, because I mean basically master, I mean দেখছি যে পাবলিক এই এরকম যদি এক্সাম্পল থাকে যে ডাবল স্পিডে একটা ইকেজি কেমন,
প্লিজ
তারপরে
হাফিজ it's on live actually.
হ্যাঁ না কেস দিয়ে শুরু করলে বেটার
Yeah, okay, sure. But this was actually a basic fundamental lecture. I want to say a few things about Jamil. I mean, when I grew up, I learned from my teachers two things: their knowledge, but that was the minor part. I always studied the individual. You look at Jamil, he looks like a religious person, and he is a religious person. That's one. Number two, he lives a life of religion. That is more important than being religious. Third, what he has done, he's a musician and a poet. That means he has shown that there is no conflict between culture and religion. And this is an unique individual. I consider it a privilege to know him. And I would like all of you to learn from this guy. Thank you.
আমি বলতে চাচ্ছি যে শ্রোতা হিসেবে একজন ভালো শিল্পীর কাছ থেকেও কিন্তু আমরা আমাদের আবেদন করতে পারি। লতা মঙ্গেশকরকেও আমরা বলতে পারি যে ওই গানটা গান, এইভাবে গান হইলে ভালো। এক এক স্টেজের একাকী, আমি সেটা বলতেছি। জামিল ভাই, থ্যাংক ইউ সো মাচ।
ইউর ওয়েলকাম। আপনি যেভাবে বলছেন যেভাবে আমি ওই যে কোরিলেশন অফ নরমাল এন্ড ডিজিজ ইসিজি অর
ফার্স্ট অফ অল অডিয়েন্সকে যদি আপনি একটা চ্যালেঞ্জ ছুড়ে দেন, what do you think about this EKG? Half will be thinking differently, and then you say you pay attention. And in this regard, I want to give a compliment to Dr. Arun Maski's team. I have noticed when somebody from Nepal starts reading EKG, they actually say the calibration as a rule or as the presentation. So that means you are paying attention to the calibration. That's like, and then pay heart rate and blood pressure and all that.
I would arrange another separate lecture. What you are asking for was the different standardization ECG, different speed ECG with different speed, and also different waveforms, normal variation. I would try to collect those things and show in another day.
So, Chaudhary Hafizul Hasan. Ji, now the floor is yours.
I'm trying to get this shared screen. Why? একটা সেকেন্ড দাঁড়ান
হাফিজ ভাই, আমি কি 4 মিনিট সময় নিব?
বলো বলো বলো।
আমি একটু দেখা যাচ্ছে যে ভাই যেটা বলছিলেন, তো আমি একটু শেয়ার করি একটা জিনিস। 1 মিনিট হয়ে গেল।
স্ক্রিন শেয়ার।
দেখা যাচ্ছে?
হ্যাঁ, ইয়েস।
আচ্ছা, এইটা আমি দেখাচ্ছিলাম। ওই যে আপনি যেটা বলছিলেন সেটা আসলে করেছিলাম আমি কিছু জিনিস। এটা নড়ে না কেন? এই যে স্ট্যান্ডার্ডাইজেশনে কি ইম্পর্টেন্ট? This is the standardization 1 millivolt 10 millimeter. Same patient, when it is 20 millimeter, it looks like the other way. Same patient 2.5 millimeter. And that's what I was paying attention. You are saying, asking for the example. We have some example. And Jamil Bhai has mentioned some of the ECGs has 10 by 5 calibration, 10 millimeter for the limb leads and 5 millimeter for the precordial leads. That's an example for that. I mean, the speed is so important. 25 millimeter per second, same patient, when it goes into 10 millimeter per second, it looks tachycardia. When it is 50 millimeter per second, it looks like bradycardia. These are important things. As we have said, the examples are actually can show what we can find.
স্যার, আমার একটা প্রশ্ন আছে স্যার, করব স্যার? ডক্টর শফিক স্যার, 20 millimeter per volt হবে না, এটা 20 millimeter per 2 volt? Actually the ECG is done by 1 millivolt. When we increase the volt, it would be 20 millimeter. If we decrease the volt, that is 0.5 millivolt, then the vertically it would be 5 millimeter.
No, Shafiq,
Yes,
actually the standardization is done. The standard is 1 millivolt will be 10 millimeter.
10 millimeter, right, sir.
But you can make it 1 millivolt producing a 20 millimeter deflection or
No,
a
sir.
0.5 millimeter.
That's what I want to know. Actually, sir, if we can make it 2 millivolt, then it would be 20 millimeter. If we do the ECG by 2 millivolt, then it would be 20 millimeter. That is how we decrease but divide the total QRS complex by 2 to get the actual voltage.
I'm confused what you were saying.
No, Shafik.
I'm confused, totally confused.
Shafik, actually, Shafik, you have to calculate always 1 millivolt equal to 5 millimeter, 1 millivolt equal to 10 millimeter, or 1 millivolt is
1
fixed.
millivolt is the standardization. That's equal to
millivolt is
deflection
fixed.
will be
Then-
somewhat
then
more or
1
less.
millivolt may be equal to 5 millimeter, 10 millimeter, 20 millimeter, 40 millimeter, 50 millimeter, whatever you like. But 1 millivolt is fixed.
But ECG is done by 1 millivolt.
1 millivolt.
1
that is
millivolt. 1
1
millivolt equal to deflection is produced in a different lengthwise. Amplification will be as you wish.
So I think Chaudhary Hafizul Hasan, he's ready, I think. Thank you,
Thanks, sir.
Professor Abdullah Chaudhary, for showing the basic things again.
Sir, in the meantime, one of our participants asked why the AVR, AVL, and AVF called augmented leads.
আচ্ছা, আমার মনে হয় তুষার,
Sir,
মানে you can discuss this issue during the actually Chaudhary Hafiz lecture, na? মানে
Okay,
let
sir.
me start the lecture.
Okay, sir. No, there was delay, that's why I asked the thing.
Chaudhary.
Hafiz, are you there?
Yes, sir. Hafiz sir is there, but he's
Hafiz, you can start.
Hafiz sir, we're seeing your slides. Sir, can you please start?
Hafiz, you are mute. Please unmute.
Me?
Now
Can
we
you
can
hear
hear
me?
you.
Okay, so sorry, 48-year-old with heart failure, EF35, that's a mistake. Now 55 because recovered from non-ischemic cardiomyopathy. And then this is the medications. What do you think about this EKG?
Do you want volunteers?
Yeah,
So any volunteers from Nepal?
Sir, shall I try, sir?
Yes, yes.
yeah.
Vishal Shrestha, welcome.
So, good evening, respected sirs. So, this is a 12-lead ECG with rhythm strip taken in standard calibration with in regard to speed and voltage, which showed regular narrow complex tachycardia at the rate around 120, 130, sorry, 170, 180. And the rate is around that. The P is there is short RP tachycardia. The RP segment is less than the PR segment, and the axis is normal. And yes, sir. So I think this is at a short RP supraventricular tachycardia. Yes.
Rafiq bhai, will you add anything?
Okay. Interesting, Hafiz, you showed this ECG yesterday. There was a patient at the clinic actually on Friday. Came with heart failure symptoms and was in a tachycardia exactly like this. And then we looked up that she basically was in tachycardia for days, if not months, causing a weak heart. I mean, so I agree with his evaluation. I mean, supraventricular tachycardia, there is a possible P wave. Rate is 166. So it's a little too fast for 2-to-1 flutter, a little too slow for 1-to-1 flutter.
Yeah, yeah.
So it's a reentrant tachycardia.
And then there is a little bit of voltage, maybe LVH. And then I would request you not to read too much on the ST segment and AVR. Sometimes the emergency room physicians read too much into it and then call for multi-vessel and left main. In a situation of tachycardia and some underlying LVH, it is not better not to overread. So what happened that adenosine given, and this was the rhythm. And remember, this is a patient with recovered non-ischemic cardiomyopathy. EF now better. It was 35 before, now 55. And this is the EKG. So the physician from Nepal, I congratulate you because I think I would agree with you. But that is like, now this is for higher level. If you can tell me that what are these extra heartbeats and where they are coming from. And this one I collected because I was thinking, oh, AVNRT, adenosine, good, beta blocker home, think about ablation if there is a recurrence. But then this EKG makes me wonder what else going on. And I was thinking, I was hoping that Rafiq bhai will be in the audience. What do you think? The physician from Nepal. Sorry, I forgot your name.
So
Vishal.
yes.
Vishal. Okay. Right.
So there is every third beat. There is one extra bit that is white complex with RBB morphology. I think it comes almost maybe just pre-excited, like not pre-excited. What is that? PACs like thing. So I think this is PACs with aberrant conduction every third beat.
Hmm.
Another DD would be obviously the ventricular beat, but I will go more on supraventricular beat with the aberrancy, sir.
Okay.
Every third beat, first, second, third, and four beats.
But you think that the compensatory pause and this is multiple of that?
But yes, sir. I have to calculate those by like time frame. If there is not exact compensation, then I'll think more as the, because this RBP is more common in aberrancy.
Yeah. Can I just, Michelle, let's work
Yes,
with
sir.
it. So it's the premature bit, no question about it. It's a wide
Yes.
QRS premature bit. So, and of course in lead V1 looks like right bundle, but look at it, that is the initial Q wave. So that kind of takes away the typical aberration of right bundle morphology. And if you look at lead 1, also the terminal S is too deep for right bundle. So clearly the beat is coming from the left side, but I do not believe that this is a right bundle aberration. That's number one. Number two, if you look at the pause, it's basically the RR interval in the during sinus beat is 560 millisecond, and it's exactly double the interval in between the holding the PVC array is double of that interval. So between these two, it makes the ventricular premature beat more likely than a aberration.
And in lead 1, the aberrant beat, it completely changes the axis. Usually if it is aberrancy, it remain the aberrancy, the change of axis is not there. So
Abhij bhai, can I say something? Abhij bhai, can I say something?
Yeah.
The morphology of the premature beat in the V1 is QR pattern, and inferior lead is 2-3 way positive. It is most likely arising from the AMs, that is aortomitral continuity.
Okay. So, so first of all, I would ask the audience that to notice that how Rafiq bhai explained this like a medical student, you know, that's very amazing. And the second thing is that that was Mohsin, right?
So
we are like general cardiologists. Let's follow, like you are EP guy, you jumped, and I'm going to come to that. So this is right bundle pattern, looks like PVC coming inferior axis, so coming from the outflow tract, and most likely probably from the RVOT, or can it be LVOT? So the transition is in V3, V4, right? So right band pattern suggests origin in LV, left ventricular pattern suggests RV or IV septum. But inferior axis is outflow tract. But here is the caveat, that is it coming from the aortomitral, or is it from purely right ventricular outflow tract, or LV outflow tract, because the LV, this is more of an RBB pattern. So is Rafiq bhai, any comment?
No, the question is whether it's coming from the right or left side. That's the issue. And then, of course, if we go into more detail into this business, which will be beyond the scope of this lecture, then you look at transition. Simple. Remember, Hafiz is actually showing the transition to see which part is coming from, to give us some idea of it.
Right.
Yes.
But I think, Rafiq bhai, for generally speaking, we don't need to worry too much about it, as long as we can say that this is coming from the outflow tract and it is PVC. Yeah. What we do with this patient? EKG from the previous admission was like this. And now we are seeing extra heartbeat to convince you that the structurally normal heart now LV is normal. So I wanted to ask you that whether you agree with the recommendation to give flecainide at this point.
Patient has non-ischemic cardiomyopathy, so flecainide can be used.
Non-ischemic cardiomyopathy and recovered, Wadud.
Yeah.
So which is much better. So I don't normally like to give flecainide, but I think beta blocker alone would have been okay. And then follow up. And if it is too much symptomatic, then think about EP ablation. But this is just one observation, so we can follow up. Interesting.
Can I make a comment?
Yeah.
The question is, why do we treat an arrhythmia? That's the basic question. One is, primary is to increase survival. Number one. Number two, to prevent something from happening in future. Like if somebody is in SVT incessant, we have to take care of the other, otherwise they will develop. Third will be symptomatic. Somebody with history of cardiomyopathy, I will be very reluctant to use flecainide.
Yeah.
And ejection fraction now is 50%, right?
Yeah.
Yeah,
55.
so it's not normal. So even if it is normal, I'll be very hesitant. I mean, if you want to use something, one drug that can be considered is sotalol, which is a beta blocker, and it may help. Pvc ablation, of course, is a huge big territory. The question would be who to ablate. I personally don't ablate just for symptom. I go for if
maximum
somebody has
medical therapy.
Yes, if it helps long term. But this is a interesting case, Hafiz. So what did they do EP study on the SVT? What did they find?
No, this is on follow up.
Yes. So please bring it back. Yeah. I think this probably has a concealed accessory pathway rather than a venode reentry. So please
you mean the initial arrhythmia, the SVT.
Yes, because if the notch was in the T wave rather than in the ST segment, so the RP interval is more than 80 milliseconds, and that supports more concealed pathway. But a lot of times we are wrong. So I'll be curious to see what the result comes back.
I don't know, Rafiq bhai, this exists, but sometimes we talk about short RP and then long RP. Sometimes there is an intermediate RP.
Oh yes, no question. Thank you.
Can I ask you a question?
Yes, please.
This patient recovered on correct, and the ejection fraction come out from 35 to 55. But if we started sotalol, can the EF suffer?
Oh, so the question is, let's give you an extreme scenario. Somebody with ejection fraction of 35% or 30 to 35%, New York Heart Class 2 symptom, normal kidney function, has an ICD as having recurrent VT, and the patient is 55-year-old. We can actually carefully start sotalol. So the problem with sotalol, that sotalol will not depress LV function, but it can precipitate heart failure.
Yes.
So, of course, as the ejection fraction goes up, then we become less worried about it. So that will be the thing. And the reason we use a lot of sotalol nowadays, because it has no long-term side effect, because once you start amiodarone or drugs like that, you cannot go backward. It's very difficult to do that.
And I have not seen any study on using carvedilol and sotalol together.
No.
But often we see the electrophysiologists and heart failure guys, they use it sometimes. They use both, which is amazing to me, because of the same fear of just what it said.
Yeah. Oh, no, Hafiz, I agree with you. We have combination, very few, because if somebody's ejection fraction 35%, let's say was 20%, improved to 35 on carvedilol, I'll be very hesitant to decrease carvedilol. In those patients, I'll avoid. I'm talking about somebody where, in this patient, where EF is now 35%, and if you really, really have to use it, you can keep on a follow-up and try it.
Yeah, and I was more in favor of just maximizing carvedilol dose and follow up rather than use flecainide.
Oh, definitely.
Yeah.
No question. I mean, listen, this PVC will be fine. I mean, the patient has improved. I'll tell the patient, live with it.
Yes. Yes. So next patient is a 63-year-old lady came into the ER, history of COPD. And this rhythm is anyone. This is a very easy one.
Anyone from Nepal?
Hello?
Yes, yes, sir. Sir, shall I try?
Sharma?
Good yes, evening, sir.
Yes, Sharma.
Yes, sir. Shall I try?
Sharma, go ahead.
Yes, sir. This is 12-lead ECG calibrated with 10 millivolt per millivolt with the speed of 25 millimeter per second. In this ECG, coming to the rhythm strip, there is, although it is irregular rhythm, I could see some P wave in between this, and PR is variable, and even P wave looks multiple morphological P wave are there, and it is irregular rhythm, and QRS it's looks LBBB type of morphology, and ST segment it's so it's likely, sir, it is irregular rhythm with multiple. There are different morphology of P wave. With the history of COPD, it looks like multifocal atrial tachycardia with LBBB morphology, sir.
Right. So tachycardia or bradycardia? Tachycardia. Regular or irregular? Irregular. Narrow or wide? Wide complex.
Wide.
So the irregularly irregular or regularly irregular? Irregularly
irregular.
So it is, the differential is AFib or multifocal atrial tach in this case. And then, so this patient then came back to sinus rhythm with this EKG. What is the explanation of the previous EKG? Now that one dose of IV metoprolol reverted back to this rhythm.
Sir, this rhythm is a sinus rhythm, sir. With the LVV changed into the narrow complex rhythm, sir.
So patient had a history of catheter-related thrombosis from the dialysis catheter. It started on Aliquis, and then metoprolol went home. LV function was normal, and the question is that what is the mechanism of rate-related left bundle? And you can read this in the book. Is the phase 3 issues and faster rate, and you get the left bundle morphology. And then because the LV function normal, we did not feel compelled to do ischemia workup in the hospital. Troponin was negative, so all good. So we are running out of time. Let me finish with this case because this is way more interesting to me. 47-year-old with chest discomfort, and then no dyspnea, cough, or leg swelling. Recent history of non-adherence to the alcohol, to medicine, and then alcohol binge, and history of liver issues. INR is high without coumadin. Bilirubin is abnormal, and then these are the vitals. Blood pressure good, heart rate a little bit high, temperature normal, and this is the baseline EKG on arrival. Anyone to make any comment? Sinus rhythm, old inferior, and that's what I read. And the patient had more discomfort in the ER, belly, epigastric, and then went to this. So let me show you this. This is old inferior sinus rhythm. That's the way we read it. And this is the rhythm in the ER. What's going on?
Manoj Koirala.
Yes, sir. Sir, good evening, sir.
Yeah, Manoj.
Sir, this is the ECG of this patient, and this is 12 lead ECG, and the calibration is not shown here, probably normally calibrated.
Normally
And,
calibrated.
Yeah, normally calibrated.
Sorry, I
we
did
can
cut out the lower panel. Yeah.
Yeah, we can see the in the left, on the right, we can see the 1 millivolt. This is the normally calibrated. And in this,
so if you compare with the previous EKG, previous patient, this is tachycardia. This is wide complex.
Wide
this
complex
is regular.
tachycardia.
Is it too wide or wide complex?
Sir, this ECG is in V1, it is a positive, so it is a right bundle branch block type, and if it is more than 140 milliseconds, it is wide. It is a wide. It's more suggestive of ventricular tachycardia, sir. So this is a wide and more than 140 milliseconds. I can see in V1, and I can see here the concordance, the QR complex, the RS complex are discordant. V1, V2, V3, V4, V5 are concordant. V6 is discordant, and the RS distance is less than 100 here, and less than 100. I think, sir, it is a wide complex tachycardia with aberrancy, probably supraventricular tachycardia with aberrancy, sir. And the AVR, we can see here in AVR, the first, there is a negative. The negative portion is there in AVR. So calculating BIVT is also, I think, more than 1, less than 1. And I cannot see here any fusion bit or any capture bit here. So I think it is a supraventricular tachycardia with aberrancy, sir. My opinion.
Okay, so what you said, your observations, I totally agree. But let me tell you this non-EP way of saying things, and then I'm going to ask Rafiq Bhai to say EP way, so and make it interesting. So non-EP way is the following: whatever you said is good, but it is really wide complex tachycardia. Nobody will disagree with that, and it is also important that there is a distinct pathologic Q wave in the inferior lead. That is no way near a physiologic Q wave. I think everybody in this room will agree that this is a and you may even argue, is there any recent MI in that because of the ST elevations in the inferior lead? And the patient had some discomfort. So you need to take the context also. So with that pathologic Q wave present and the patient presenting with wide complex tachycardia and in the ER. So I don't want you to bet, but if you want to bet for the wide complex tachycardia differential being VT versus SVT with aberrancy, where will you put your money in? You will put your money in VTAC until proven otherwise. But you keep that in mind. And life sometimes favors you. Patient dropped blood pressure, shocked. And then the EKG came back like this.
Hafiz, can you go back, please?
Yeah,
go back.
I was waiting for you, but I'm just giving you the non-EP way of saying
so
things. Also,
what was,
I think Rafiq Bhai,
I'm sorry, I missed a little.
Almost 160.
Yeah. I missed a little bit. What was Manoj's diagnosis?
SVT with aberrancy.
Okay, fine. I mean, that's a possibility.
Yeah.
So look at it. Wide QRS tachycardia of right bundle morphology. So it can be SVT or VT with right bundle aberration. There is no AV dissociation. Look at the QRS duration. QRS duration is about 160 milliseconds. With right bundle, QRS more than 140 milliseconds favors VT. Then I cannot see RSR, definite RSR pattern in V1. So that takes it away. Look at the ratio of R wave and S wave in V6. It's less than 1. If it were right bundle aberration, it would be more than 1 because the R will be bigger than the S wave. Even without the clinical context of anything, if this patient comes to me, I don't know anything about this patient. Based on those, it is VT. And even if it is as VT, clinically, we have to treat it as VT. A ventricular tachycardia, no question about it.
Yeah, and then
Thank
this
you.
is too wide. And will you have any comment on the axis?
Axis.
If you look at 2-3 AVF, it's negative. So that means it's coming from the left side from the inferior surface. And
Yeah.
it's a very, very common thing that happens with inferior MI, that you get a VT between the scar and the mitral annulus.
Yeah. And that is
that's
very
why they come.
important in this case, because I showed you the EKG here. The baseline EKG, there is a distinct pathologic Q wave present, which is no question about it. So and then the explanation that in lead V3, V2, you see looks like a part of the QRS or maybe a P wave. So yeah, so it can be a one-to-one VA conduction, or it can be just part of the QRS. I would not put too much money into it. Sometimes that can be deceiving. So this patient then had this further workup. Look at the LDL, despite the cirrhosis, and the troponin was a little bit positive. And this is the EKG after cardioversion. What we do now? The platelet count, we love platelets in interventional cardiology. Cirrhosis patient alcohol platelets 49,000, not good.
I mean, Hafiz, I mean, there is no urgency, but eventually this patient will need the anatomy defined.
Okay, so this is the echo first, I show you.
Yes.
This is definitely was used for left ventricular opacification. So any comment, Wadud? And then we did the angiogram. Wadud? Any so LV not normal. And actually, even with the LV opacification, LV was bad. And this was the angiogram. No surprise that the RCA is several tandem lesions, severe diffuse disease from the mid to distal, and the distal is gone. And then you can see that there is a good collateral flow from the left system. And then LAD in the LAO-crani projection is good. And the LAD proximal, mid, and distal looks good. And there is collateral flow going to the right. But here is the problem on the circ system. So the left circumflex gives off the OM branch. And then the circumflex itself goes into the groove, but gives a second OM branch. And the ostium of that left circumflex, this is better. After giving off the OM branch, there is an ostial disease. And immediately after that, there is a coronary ectasia. So question is, what do we do now? And this is a time when the electrophysiologist and interventionalist need to come together. What do we do now? Troponin, these are the troponins. So on admission versus now. And so what do you do now?
Well, Hafiz, that's of course we will always like to have substrate fixed. But
Right, but my question is, Rafiq bhai,
yes,
you saw that this was a monomorphic VT,
yes,
and this is the coronary anatomy.
yes.
So I see Ashok in the panel.
Yes.
Ashok,
Yes, sir.
Dr.
Yes, sir.
Professor Datta. So
Yes, sir.
sorry, I call you on your first name.
Just we can relook to the right coronary.
Yeah.
That is the culprit vessel now. Though there is a good collateral, but that occluded, I think, recently occluded.
Right.
RCA is a big vessel.
But this is a very diffuse disease,
But
and
anyhow, this
and
vessel, we should fix it.
okay. So this is the part I do not have. So we thought, Rafiq bhai, that this is a scar-related VT. The inferior wall was hypokinetic, akinetic, and actually in some view looks like dyskinetic. And when we have done this before, that we do a viability scan there and then see whether this is viable or not. Do we have any data on this? No. Can you argue that why not go after the right? We thought that going after the right at this late, we may not see much. But if we believe that this is a scar-related VT, then what is the point? So, but you can disagree. And
Well,
then some said that why not fix the circumflex?
Hafiz.
Yeah.
So the decision about treating the VT is simple, because VT is not caused by ischemia. You already have a scar.
Right.
And patient with cardiomyopathy will not be defibrillated. The decision about the intervention is a very, very difficult, because that RCA is a very long lesion, and there is collateral flow. Are you going to gain much if you fix the RCA, or are you going to get into more trouble trying to fix it? That
right.
is,
And my another big argument was, and I'm bringing this issue up. So to be good cardiologist, we also, to be interventionalist or EP, we also need to be good cardiologist. And to be good cardiologist, we need to be good clinicians and internal medicine. My argument to the fellows and to the whole team is that, look, if I fix the RCA, this will be a long full metal jacket, and the platelet count of this patient is 49. Okay. So, and the patient has cirrhosis of liver, and the patient has alcohol and history of non-compliance. So all these to be taken into consideration. About the circumflex, if we fix that, this is basically an easy bifurcation lesion. We can fix it, but is it going to solve the problem? And we may still have this issue about dual antiplatelet stenting. So I was more in favor of not going for anything.
Hafiz,
but the question is, yeah.
LAD is quite good. So I would go for just VT protection and aggressive intensive medical therapy.
Now the VT, for the VT, we all agree this will be not a primary prevention. This is a secondary prevention.
Yeah.
But the secondary prevention, we have no excuse not to put an ICD.
Yeah.
Will you put an ICD with the platelet count of 48?
Why not?
Technically, I mean, I have done 50. So it's tough. If there is no aspirin or something, I mean, we have done, I'll give platelet transfusion and then put an ICD in.
So, Rohit bhai, we told our electrophysiology colleague that to put an ICD, because this is a secondary prevention, it is very difficult not to put an ICD and protect this guy, because he had sustained monomorphic VT, dropped blood pressure. So next time that happens, it may kill him. So problem was that, and this is my question to you, ultimately, we did not get the access from the left. So we got the access from the right. And is there any concern that when we put an ICD from the right?
So why couldn't they get access on the left?
They could not get the access on the left. They could not get any blood back. And they thought that they tried a few times. I don't know exactly.
Did they do a venogram?
They did not do any venogram. They did not get any access.
Yeah, no, I mean, this is the problem part.
Yeah.
Right side is less effective than on the left side. Left side. So if somebody has EF of 45-50, I have no problem putting a right-sided lead. So on the this guy's EF is very low, and with this kind of disease, I am sure what happened. You were an academic program. It was done by a fellow, and fellow did a little bit. He just gave up and went to the right side. That's the typical scenario. I would, before I give up on the left side, I would have done a venogram to make sure that the vein is occluded or not occluded. That's the part. The other thing, if you can you show me the picture? I'm going to talk about a little bit. It's a little bit. If you look at that right ventricle, there is the electrode, which is the shocking coil. And then the can is the shocking coil, and then the superior vena cava coil is the shocking coil. A dual coil is not as much effective because all the energy is on the right side rather than on the left side. So that's the problem.
Yes,
but it works.
So Rohit, thank you so much, because I saw this chest X-ray and I told the fellows, what the heck, that why did you do this? And then my question is that in that case, this patient does not need a pacemaker because he never had any bloody issue. Why not sub-Q ICD when we have because will you trust more a sub-Q ICD than a right-sided ICD?
Okay, so the question is subcutaneous versus right-sided ICD. In this patient, I will avoid a sub-Q ICD because ATP will not work. Second, efficacy-wise, no question, transvenous will be better. Right-sided, I would favor a right-sided transvenous over a subcutaneous. And a sub-Q ICD is good for prophylactic ICDs. That's my personal view.
For the secondary prevention is a real
secondary prevention. Now, I think I'll go for transvenous.
Okay. So and my argument to the fellow was.
Hafiz, can I add something?
Yeah.
For the young participants, remember Rafiq sir was saying this patient has MI, so the VT is related to scar. That means it's a reentrant tachycardia. And if it was acute ischemia, he would have rather VF. That's what he always says, and we should remember that.
Like polymorphic VT or VF. Yeah.
Yeah. Or good polymorphic point. VT.
Yeah. So and also my suggestion to the fellow in the round was that when this happens, I don't know, Rafiq Bhai, what do you say? I said you stop the procedure rather than going and jumping and finishing from the right. You can ask the radiologist, or you can do it yourself from the brachial side, go with the catheter, visualize the venogram, find out the problem, and then decide. Sometimes you see persistent left-sided superior vena cava. Sometimes you're worried about any pneumo, and that has to be sorted out before, because this is not like emergency to put a right-sided ICD right away and then finish the procedure on that day. Would you have deferred this, Rafiq Bhai?
No.
And then go for
I'll tell you exactly what happened with this patient. Yeah. So initially when I saw the picture, I thought patient was on dialysis. That's why they went on the right side. Yeah. So they did not have an IV on the left side.
Right.
That's one thing I do. Before I take my patient for any device, I have IV on both sides. And they have made a cut. before I abandon a cut, I will say, let's move the table, let's put an IV on the left arm, let's do a venogram.
Yeah.
And you find the best person to come and find a puncture. I mean, I have been doing device for many years. Even 5-6 years ago, I had a case where it was very difficult. I called the radiology person. There is no shame in it. It's just changing a hand can make the puncture easier. Because when I am doing the puncture, even though I am doing it and I'm changing my position, my brain takes it to the same place, even though I'm thinking I'm puncturing differently. You get a new set of hands, they will find it. And there's nothing to do with experience. I mean, it's just the way we are. Seek help, get somebody to do it.
Exactly. And I just wanted to point out to the audience that it starts with a simple EKG. This is appropriately, this session is named EKG and beyond. That initial EKG and the clinical presentation, that Q wave, whole totality of the information, how that evolved, the patient's care and the decision making is so important, because this is a secondary prevention. This coil is there for a purpose. And if you want a good value for the device, you need to think about the patient in totality. So I thought that this is a very interesting case. And my job is also to look at the beyond part of the EKG session. And we have a lot of faculty. I just wanted to share the experience.
Sure.
Thank you.
Shall we stop here today? It's 1.5 hours.
Thank you, sir.
Thank you, sir. Great
Sir,
program.
assalamu alaikum. Hello.
Habiba.
Hello.
স্যার আসসালামু আলাইকুম স্যার আমার একটা কোয়েশ্চেন ছিল স্যার স্যার এটা তো একটা মনোমরফিক ভিটি তো বোঝা যাচ্ছে যে ইনফেরিয়র অরিজিন সো এখানে যে ভিটি অ্যাবলেশন এর রোল আছে কি স্যার
Okay.
Shall I answer?
Yeah, of course.
Rafik sir.
I knew that this would come.
Okay. So please remember one thing for the audience. Lot of background noise, please. Okay. VT ablation, please remember, VT ablation is not a cure. VT ablation is palliation, especially in a substrate like this. Unless it is idiopathic VT, we are not curing it. So even if I do an ablation, I will have to put a defibrillator in this patient. And ablation in this patient is not a very simple ablation. It's a complex patient. So I will put an ICD in. Patient gets one shock once a year or twice a year. I'll do nothing about it. Patient gets VT every week or every 2 months. Then I'm going to refer the patient for VT ablation. If medication doesn't suppress it. Medication means in a young person, I will not use amiodarone. I will try other medicine if it is available.
That was suggested, Rafiq Bhai, and then I said no, because also there's a patient has alcoholic liver disease and cirrhosis. So I said absolutely not. But we have scientists in the team. The fellows are always scientists. I tell them, think about the global. So we did. So I apologize to Atar Bhai and Wadud. I dropped the audience from 101 to 65. Jamil Bhai rock music এর পরে আমাকে দিছে classics. So that is going to happen.
স্যার রফিক স্যার আমাকে একটা প্রশ্ন আছে স্যার
আমি ক্লাসিক বলছি আপনি রক করছেন
সিঙ্গেল কয়েল এন্ড ডাবল কয়েলের ভিতরে প্রেফারেন্সিয়াল কোনটা হবে
আমি কোশ্চেনটা করতে যাচ্ছিলাম
I have been traditionally in favor of single coil. For the difference between DFT between single and double coil is actually 1 joules. It's not a huge difference. If the heart size is normal, let's do it other way. Unless the heart size is very big, and when I talk about very big, I talk about 7 to 8 centimeter or above. We use single coil lead, because if you ever have to extract the lead, the main point where it get adhesion and which can be dangerous is superior vena cava. And that's why we have switched mostly to single coil lead at this point.
So Rohit, that's a very interesting issue. So routinely, I don't know what you're doing. We are not doing NIPS routinely, but in these patients, I actually demanded NIPS non-invasive programmed stimulation. Any comment on that, Rafiq bhai?
Traditionally, I have tested all my patients. But if you look at patients that have low EF, I always test them. If the EF is over 35 or more, I know it is going to work. And in this case, asking for NIPS is an excellent idea. I will do it. So what I do in a patient with VT, I want to know if the ATP works. Especially also when you have put a device on the right side, I will definitely test it, make sure it works. And people have a tendency to avoid testing when the EF is low. But guess what? That is the person that's going to die when the ICD will not work. That is the person you need to test.
So this is like, Ashok, this is like routine aspiration in STEMI. So routine NIPS is not needed, JACC publication, but there are some exceptions, and this is one of them.
Sure.
Thank you. Thank you.
Thank you, sir.
So Abdul Aziz Chaudhary, please.
Thank you, everybody. Today we have discussion about the very basic things, and then the complex decision that comes from a very simple presentation resulting into complex situation, and then decision about a complex situation, why this should not be done, why that should be done. What we need is explanation is easy term, and that's what we have got here. Thank you, Professor Jamil Bhai. Thank you very much for your nice presentation, and thank you, Professor Rafiq sir and Hafiz Bhai, because you have shown us a thrilling clinical presentation, a simple thing that can result in very difficult situation, what to do. And we get some real idea about real case scenarios from that. Thank you very much.
So Ribu, thank you very much. Ribu, we can close.
After 2 weeks again, we'll meet.
Thank you. Good night, sir.
Ashok, join করার জন্য thank you.
Thank you, sir.
আসলে মাঝে মধ্যে আসলে আমাদের ভালো লাগবে।
আমি গত ইয়েটা মিস করছি আতার ভাইটা।
Our next
আর অশোক তো অশোক